lower blood pressure, how much you speed up heart rate, whatever it is, that's the response. And as you might expect for many, many drugs, the more you give, the more response you get. And if you give a really, really small amount, you might not get any response at all. And then at some point you'll start to get a response, and that response will go up, and then usually there's a maximal response that you'll achieve. And even if you give more drug after that, you won't go any higher than the maximal response. There's two terms that are used interchangeably a lot, and but they mean very different things, and they're drug potency and drug efficacy. And so what we have here is we have two drugs, the blue drug and the red drug. And on the bottom, we have an increasing concentration of drug, and on the top, we have an increasing, or on the y-axis, we have an increasing effect of the drug. And if you look at the two drugs on the left, the blue and the red drug, you can see that if you give enough, as we're giving more and more of the drug, you can get the maximal effect. So if you give enough of the red drug, you can get 100% of the effect. Same if you give enough of the blue drug. But if this is a concentration from low to high, we get the maximal effect with the blue drug at a much lower concentration than we need to get the maximal effect with the red drug. So we say that the blue drug is more potent. We need less of it to get an effect, or our maximal effect. And on the right, we have two drugs that actually have the same potency, but the blue drug can give us a higher maximal effect than the red drug. Even if we give loads and loads and loads of the red drug, we can never get to that maximal effect we can achieve with the blue drug. And so we say that the blue drug has a higher efficacy. And those are important because sometimes the word potency is thought to mean more effective, but it really just means how much you need. So, for example, you can have an opioid like fentanyl, which is a very potent opioid receptor agonist. So it's a morphine-like drug, used mostly for very chronic cancer pain and pain in terminally ill patients. And it's over 100 times more potent than morphine. But you can still get the same level of analgesia with each. You'll just have to give a lot more morphine than you have to use fentanyl. So potency is an important definition. Efficacy, sometimes we'll see the word Emax, which is the maximal efficacy. Potency is usually described by something called the EC50. And that's just a way of describing at what concentration of a drug do you get 50% of the maximal response. Or it could be ED50, or what dose of the drug do you get maximal response. But then we also need to describe toxic effects of drugs, and you'll see the term TD50, the dose at which 50% of a group of individuals observe a toxic effect, or you get 50% of the maximal toxic effect. And these terms can allow us to come up with something called a therapeutic window, which we'll talk about when we talk about recreational drugs. And the therapeutic window means how much, it's a ratio of how much drug you need to see a toxic effect over how much drug you need to see your therapeutic effect, or in the case of recreational drugs, your high or something. And it was, I don't usually feel that old because I'm still a relatively young professor. But I kind of assumed in my class that everyone knew what LSD was. Like, I thought it was just kind of common knowledge. But apparently I was mistaken. So I asked this very clever question. We're talking about anticholinergic drugs, and you can achieve hallucinations with anticholinergic drugs if you want, but there's a very, very narrow therapeutic window, so you end up with all sorts of side effects before you really get a good hallucinatory effect. Whereas with LSD, that's actually an extremely wide therapeutic window. So the question was, why would LSD be a better choice to hallucinate than this anticholinergic drug? And so a couple students put up their hand and said, "What's LSD?" And I said, "It's, like acid." and they were like, what kind of acid? And so I realized that maybe next time I'll have to explain what it was. It's not as common these days, I suppose, but anyway. I'm going to skip over these next few slides, but all they really were there to show was that we actually have the whole field of medicinal chemistry and computational chemistry and in silico computational chemistry has really expanded immensely in the last 50 years, and we now can not only design and synthesize very quickly a bunch of different drugs if we're trying to test them out for, and a drug company wants to find a drug and market it, but we can also use computer modeling now to a high degree to predict which drugs we should go make and then go test. So the question of homeostasis came up, and so I like to say that the body doesn't respond. The response of the body to a drug is more than just administering a drug and having the body respond. What it really is, it's that plus how the body responds to how the body responds to the drug. Because all of these systems are so balanced, and this is an example of thyroid hormone regulation. So thyroid hormone regulation starts in the hypothalamus, and it sends a signal to the pituitary. The pituitary sends a big signal to the thyroid and says we need more thyroid hormone. And then this will release thyroid hormone, and then that thyroid hormone will go back and tell the hypothalamus and the pituitary to stop because we've got plenty of thyroid hormone. And then when the thyroid hormone levels drop and these negative feedback loops aren't there anymore, then the whole thing will start up again, you'll replenish the thyroid hormone. And this system is set up this way so you'll always have a certain level or a normal level of thyroid hormone. So you can start to use this example then and think, well, what if you just took somebody off the street and gave them loads and loads of thyroid hormone? We actually use T4 mostly. So what does that do to this system? Well, first of all, the thyroid hormone will go and target all sorts of thyroid hormone receptors, and you'll increase your metabolism and do all the things that thyroid hormone does. But what will it do to this loop? It'll tell the anterior pituitary and the hypothalamus that there's way too much thyroid hormone around, so there's no need to make any more. And it'll really shut down this negative feedback loop. And that's okay, because you want to shut down the negative feedback loop because you've got loads and loads of thyroid hormone. But what happens then if all of a sudden you've been doing that for a few weeks and then you stop it? Well, now you're in a situation where the body's has become used to getting thyroid hormone from pills. It hasn't been making it itself. So if you go cold turkey on this treatment, it'll take a couple days or a week or something for this system to really kick back in gear. We'll talk about that a little bit when we talk about tolerance and dependence of opioids.
So that's when it starts interrupting your body.
Mm-hmm. Yeah, so you've caused an imbalance, and then you need to fix it. So it's not for every action there's an equal and opposite reaction in the body, but for every action there is some sort of reaction. When you introduce an exogenous or a drug from an outside source into the body, it's usually going to cause some sort of change, and usually the body will respond by trying to oppose that change. So if you add a bunch of thyroid hormone, the body will react by reducing thyroid hormone. Some of these things can happen really, really fast. This is how blood pressure is regulated. This box represents the average arterial blood pressure. If there's a change in blood pressure, that'll be sensed in the cardiovascular centers in the brain, and they'll activate the sympathetic nervous system or the fight or flight nervous system or the parasympathetic nervous system, usually called the rest and digest nervous system. And this will react to that change by changing how hard the heart is contracting, how fast the heart is beating, and how constricted the blood vessels are. So if you add epinephrine if you inject yourself with epinephrine, if you're not having an anaphylactic reaction, you just injected yourself with epinephrine, then that would immediately cause the heart to pump harder and faster and cause your blood vessels to constrict and your blood pressure to shoot way up. So within seconds of that injection, you would turn off your sympathetic nervous system, because you would say that we've got a huge overactivation of this system. I don't know what's going on, but we don't need this turned on, and you'd probably turn on the parasympathetic nervous system to try to counter that effect of epinephrine. Is there any questions about some of these drug targets and how we describe how drugs are interacting with receptors and how they're interacting with these systems that are designed in the body to try to maintain normalcy? So I just want to take a few slides to talk about why now we're talking about whole individuals or whole organisms might respond differently to drugs. So we can describe how they interact with receptors very precisely. We can describe how they interact with systems very precisely. We can predict how they ought to affect people very precisely. But once we get drugs into the clinic, then all of a sudden when we're dealing with real people, we see a variety of responses. Most people respond as expected in some sort of normal range. Some people might respond to a greater extent, and some people might not respond as much as we would think. And so what are the factors in actual organisms that'll affect us? Species, that really refers to, as you're developing drugs or testing drugs, we know now that not everything that happens in a rat is going to happen in a human, and not everything that happens in a mouse is going to happen in a rabbit. So there's species differences with response to drug. When you're talking about people taking drugs for blood pressure, there's a whole field of compliance and whether people take their drugs as directed and take them every day. Age, as you age, there's huge changes in your liver function and your kidney function. There's changes in your fat versus muscle. These are quite large changes. For the most part, these huge changes in some of these parameters don't come out as big changes with responses to drugs, unless there's a liver or kidney dysfunction on top of it. Diseases. So how can diseases affect how the body responds to drugs? We'll take something like meningitis, which is an inflammation of the meninges of the brain. Usually the brain forms a relatively good barrier against drugs. It's called the blood-brain barrier. So a lot of drugs, especially if they're very water-soluble, don't cross into the brain very well. But then if you have meningitis and you have an inflamed meninges in the brain, all of a sudden that barrier can become a little bit porous. And so then drugs that might not normally get into the brain might start getting into the brain. So that's an example of how diseases can affect a drug response. Sex and hormones, male and female differences in humans actually are not as pronounced as in other species, so you can actually find relatively more differences in drug responses in rats, for example, than you can in humans. There are measurable differences in diet. There's differences in body water and muscle percentages. There's differences in reporting. So women report adverse drug reactions or side effects a lot more. So that also skews the potential differences. And then hormones, again, there's all sorts of hormonal systems that have the potential to affect how the body's going to respond to drugs. Diet actually can affect drugs. If you see this nomenclature, CYP, and then there's a number and a letter and a number, that refers to a family of metabolic enzymes, mostly in the liver. They're called cytochrome P450, that's where the CYP comes from. And then the specific enzyme type has this nomenclature 2E1 or 1A2. So a lot of these cytochrome P450 enzymes metabolize medicines or drugs. And we can affect their activity just by changing our diet. So if you just start fasting, one of the things that happens is your 2E1 metabolic enzyme is going to go up, and that does metabolize some drugs that we take. If you eat a lot of charcoal broiled foods, 1A1 and 1A2 go up, and that'll affect some drugs that we need to metabolize. If you drink a lot of grapefruit juice, you'll inhibit a cytochrome P450 enzyme called 3A4, and cytochrome P450 3A4 metabolizes a huge number of commercially available drugs. And so if you've ever had taken a drug where